This has been a great discussion. I want to thank everyone personally and specifically for coming. We've had review and discussion of current information and treatment strategies in different metastatic melanomas. To close, I'd like to get final thoughts from each of the panelists. Dr. Ampaka.
So, being a surgeon, as we say, I often see these patients in the earlier stage. And I think that one thing that we have not spoken about is really the prevention of melanoma. Ultimately, we know that melanoma is the #1 growing disease in the cancer in the country. And I think that we need to have more emphasis on prevention and also understanding then in patients that have high risk of developing melanoma, how do we prevent melanoma in those patients? Then, if patients do develop melanoma, I think we need to have a better understanding of biomarkers to predict who has a high risk of recurring versus not recurring. And I think that there are patients right now that we would, with the current histological markers that we have, consider have a very low risk of recurring, yet they recur. And I think that we need to put more emphasis on that. And I think that patients then with early disease have neoadjuvant approaches to try to activate the immune system prior to surgery to decrease the risk of recurrence.
Dr. Kaufman?
Yeah, no, I think these are exciting times for our patients and for the treating physicians. And certainly I think the advances in immunotherapy have been paradigm shifting. But it does require, I think, getting used to a new set of side effects and a new set of mechanisms for treatment. And so if I can plug one thing as a resource, my professional society, the Society for Immunotherapy of Cancer, or SITC, is a great resource for physicians who may want more information on how to manage patients with some of the various immunotherapy drugs. And so we have a great website which can be found at www.sitcancer.org. And there's a number of videos and slide sets and educational materials that might be very useful if people are contemplating using immunotherapy.
Both great points. Dr. Joseph?
You know, I think one of the things, you know, we talk about patients and say, you know, it's never is a good time to get melanoma, but today is a lot better than it was 5 or 6 years ago. And I say that, you know, really, I really enjoy my job at this point, being able to offer all these new therapies where we can literally look at our patients in the eye and say, hey, we have some hope for you guys. And if this therapy doesn't work, we have a whole another therapy to go with, and there's even more promising in the future. I think with that being said, there's still so many challenges that we need to be addressed. I think one of the biggest challenges that I'm seeing is, you know, the PD-1 drugs are great, but they aren't curing everybody. And how are we going to? That to me is going to be a big unmet need. What are we going to do with patients who have progressed on PD-1? The answer is not very obvious. I think another unmet need and questions that needs to be answered is clearly the IPI and Nivo combination looks superior in terms of clinical efficacy. However, the toxicity does look also worse. Where are we going to find that balance of toxicity and efficacy, and how should we start patients in the front line with the maybe not the most effective, but maybe the PD-1 have the right balance, and then go into the combination, or should we start with the most effective drug or drug combination first? I think that's going to be a really interesting way to.
Still a lot of questions to be answered. And Dr. Pavlik?
I think what we need to really remember is that we're all sitting here talking about these advances because of the clinical trials that patients have willingly gone on, knowing that there was no answer for melanoma. And so here we are with talking about these options, but I think we also need to continue to do those research studies. We need to have patients continue to participate in clinical trials because we've come this far, but we're not there yet. And that really, to me, is the biggest take-home point, is that just because we have the drugs available doesn't mean that we should overlook offering our patients clinical trials and providing them with maybe what may be the next best step.
Thank you. And for me, the point that although there's been a lot of work done there's still a whole lot of work left to do. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.